But just a bit of background to this session. Back in 2019, Shelter got me to run a series of face-to-face workshops around the state that were called Housing, Homelessness and the NDIS. And what they were just basically an introduction to the NDIS and particularly its overlap with housing and homelessness. And as part of those workshops, as well as some introductory information and having some discussion about issues that people were dealing with, we asked people, what more would you like to know about? And those questions that people had said, we'd like to know more about that, formed the basis for a series of webinars, which we've been running through this year as the pandemic has permitted and so forth. And so earlier in this year, about March, we ran one about how you help people to get on the NDIS. And then in August, we ran another one about what happens when people's supports are not working for them or when they break down, and how can you help people to work their way through that. And then this one today is about how do you coordinate the various supports that people have. And what it came out of was discussions in a number of our workshops last year where people were saying housing agencies or homelessness agencies had long-standing relationships with disability agencies and particularly with mental health agencies, which they'd built up over a number of years. And so when there was an issue that came up, they knew they could call X to come and help. And they were finding that under the NDIS, those systems weren't navigable in the same way. And they wanted to know how they could rebuild those, how these things worked under the NDIS, that kind of thing. And that's the prompt for the session that we've set up today. Now, I don't expect that the panelists will have all the answers to the various questions that raises, but this is just an opportunity for us to explore that issue a little bit more, to talk about how coordination takes place under the NDIS, how that might overlap with some of the other systems where we coordinate within the housing and homelessness sector, and you know, what we could do to keep on making that better in our own communities. So without further ado, I would like to invite the panelists to introduce themselves, beginning maybe with Mark, because you were the first to arrive this morning.
Thanks, Dylan. So yeah, my name's Mark Edmonds. I'm from the community engagement team with the NDIA, the National Disability Insurance Agency, which runs the scheme. So NDIS and NDIA are the same thing. So yeah, that's, and then, I don't know, John, is that all you need to know at the moment?
Yes, probably. Yep. That'll do us. We'll get to more soon. Andrea, would you like to let us know who you are?
Yep, hi, I'm Andrea Davidson. I work at the Cairns and Hinterland Hospital and Health Service, mental health and ATOTS, and my role is Service Integration Coordinator.
Right. And Kate?
Morning, everyone. My name's Kate Jacker. I'm the Regional Manager for NDIS Support Coordination with Mercy Community, but I'm also the manager of the ECSN program, which is the Exceptionally Complex Support Needs program that's statewide and funded by the NDIA, which supports, I guess, support coordinators to work with people with exceptionally complex support needs. So I'm kind of wearing that hat today as well.
Yeah. And I understand both Andrea and Kate, you're both involved also in the homelessness coordination networks in your communities, or at least have some contact with them?
Yes, I sit on the reference group and at the moment on the panel.
Yes, yes, because I think one of the things that's really interesting in our current context is that there's a growth that the Queensland government have funded and that Shelter are facilitating in those kind of networks around the state, and it'll be interesting to think about how those can kind of interact with the disability coordination networks, so that people don't have two coordination networks in their lives. So I just wonder if between you would be able to give us some insight, just for a start, for those who might be new to this. What are some of the key coordination mechanisms around support that operate within the NDIS? So how, particularly for people with complex, multiple supports, how are those coordinated in the normal course of events?
Is that for me, John, or
yeah,
Andrea?
you might be a good person to leap into that one.
So that's a very big question, and it could be responded to in a variety of ways. And the tricky part of the NDIS too is that it's an open provider market, so we're no longer in a block funded world where you're told exactly how to deliver and what to deliver. So a support coordinator is the role that the NDIS, I guess, fund in participants' plans. So people can choose to work with a coordinator whose role it is to coordinate their supports in whatever context that looks like. And so for people with exceptionally complex support needs or experiencing homelessness or at risk of homelessness, which is that space that we're talking about today, their support coordinator or specialist support coordinator is a key part of that puzzle, but that also involves normally a variety of other stakeholders, like any other coordination role, whether you've done it in a homelessness space or in a case management and mental health community team space. Similar kind of work where that coordinator would work with all those stakeholders, and that might mean working with like Andrea in her role. It might mean working with the mental health community case manager. It might mean working with the NDIS service providers, with the complex support needs team in the NDIS to try and support that person to stabilise their supports.
Okay, so this is something, is it that that people have specifically funded in their plans?
Well, they should, if they have complex needs or if they're experiencing homelessness or are at risk of homelessness. And my understanding of the NDIS rules and operational guidelines is that they should absolutely be funded a support coordinator. Doesn't always happen though. And also because homelessness isn't always planned, you don't always know you're going to be homeless.
Yeah.
People don't always know that's in their future even. So you could be rolling along with your NDIS plan and things are okay at your last planning meeting, but then lots of things change. And if that person hasn't had a coordinator or hasn't had lots of stable supports around them to support them, they can end up kind of lost in the system, especially if they have an LAC who's supporting them, because an LAC doesn't have capacity to have a lot of contact with the participant, So, but in this space we're working in, it would most probably be an error that someone didn't have a coordinator. But then the issue that you face is that a lot of coordinators work really differently, yeah? So not all of them come from a clinical framework, not all of them know case management like we do in that homelessness community services space. Some of the people that provide support coordination have never worked in that kind of area, so they don't understand those systems. So maybe it's about either developing those coordinator skills or that person with complex needs working with someone who has the capacity to support them in that complex space, because there's different providers suit different people. That's the tricky part of the NDIS, I think, is it's not just like homelessness where you can go to your local homelessness service, you're going to get a case manager who knows homelessness, who does it every day of the week. It's a bit different because people get to choose and every provider does it differently.
Yeah. So Sarah has asked how you get access to a support coordinator if someone's got, so assuming that they don't currently have a support coordinator, how do you help them to find one?
It's Andrea. I know when we do an NDIS application and go to a planning meeting, we absolutely emphasise the need for support coordination to be in the plan. And to me, that's the way. I know recently we did have a client who got a fairly intensive dollar-wise plan without one. So then we automatically ask for a very light touch review to make sure it was included, because it's paramount.
Okay. So if they don't have it in their plan, what's the default there? You're saying, Kate, is that done by the LAC?
Yes, yeah. So the concept being is that if you come into the scheme and you're streamed at a certain level, then you go and the LACs write your plan and support you, which is just a light touch, maybe a couple of phone calls a year, see how you're going, and then write your plan again. But if you're streamed as a higher need or more complexities around you, not necessarily even you yourself, but you may have lots of different things going on around you, or lack of supports or lack of informal supports or housing situations, then you will be streamed automatically and come through the agency and then be classed as eligible for support coordination. It doesn't mean you can't move between those two areas, but that's the issue that happens at access. So those kind of decisions are made at access point, and normally that's when a doctor's filled out some forms, or maybe there's an OT report, maybe if you're lucky, if you've been in hospital. So they don't actually have the whole picture of the person. They just might have their diagnosis. So then they come through and you see these weird first plans or first plans without coordination, despite, you know, maybe a super, like, good examples also are a super complex family with multiple kids with disabilities and parents with impairments, and nobody gets coordination, and they've got an LAC, and then, yeah, it just doesn't work.
Yeah. So LAC, for those who are new to this, stands for Local Area Coordinator. And that's like the role that the NDIS funds, which kind of provides the general coordination for people and does some of the initial assessments and some of those kind of things. So they do have a role to work with people, but they don't have a lot of resources.
And the issue...
Yeah. Sorry, go ahead.
No. And I find the issue, at least with if someone does have support coordination in an area like Cairns, for instance, I know Kate's NGO Mercy very, very well. At least we have a network, so you know who to contact, because for a local area coordinator, it's very difficult to know if a client's case managed, if they've got other services involved and things like that.
Right.
So then, you know, it's difficult to know who to be contacting, who are the appropriate people, you know, to get around the table. And that's an issue.
And finding a support coordinator is an issue for people, and your mental health teams or your NGOs understanding if someone even has a coordinator in their plan. And then lots of NGOs, and hey everyone, if people are in here and then you're not in NDIS world, it's hard to know. Like, I've been there, that's where I came from as well. You don't know, you're just so busy doing what you do, you don't know that someone actually needs that service and that it's not automatically given to them. And so people think, oh, well, NDIS will just like refer to a coordinator and then the coordinator will just have all this information about the person and then they'll come in. But that doesn't always happen. RFSs or referrals aren't always automatically made. They wait for the person to make a decision, but they don't even know what they have to decide about sometimes, so they don't make a decision. So someone can float around with a plan and not even have a coordinator or know to choose one. And then the coordinator can come in if we are appointed, and then we have no information other than that piece of NDIS plan with the dollar amounts on it and a bit about me. And so we often come in asking for a lot of information, which often annoys people because they're like, we've been doing all this work, or, you know, we thought you were going to come in and do all this stuff. And so we're going, where's this report and what's that and how's this and can we have a meeting and can we do all these things? And so often a big barrier there is so for the coordinator to build a rapport or a relationship with those other NGOs and those other services, and also for everybody to understand each other's roles and understand that we come in with, we don't even get the access information from the agency. So we don't even know their disability sometimes.
Right. So you need for the person to be able to share that with you. Is that how that works? Yeah.
Yeah.
So if someone comes to you who it's clear that they need coordination, but they don't have a coordinator in place now, what would be the first step? How would you find someone to do that, or how would you begin to go on that road?
Then, John, it's Mark here. So yeah, they need to contact the agency one way or another, whether that's through their local area coordinator. So on their plan, there'll be a contact name or a person. So if it's the local area coordinator, contact that person and say, I think I need support coordination, or the significant person that's helping them. You know, this person needs support coordination, explain the circumstances, and that will trigger a review of some description. And then equally, if the plan is done by the NDIA directly, it's more likely that they'll have support coordination there already, but they could also request a review of the plan to have. And sometimes it's that there may not be enough hours. So even if they do have support coordination, but it may not be, it may be very obvious to the support coordinator at the outset that there's going to be insufficient funding for the complexity of the situation, and that may also be required. There's also, so that's probably the easiest way to explain it.
So it's to use the review process. In the meantime, if they're in an urgent situation, is there a way to get around it temporarily?
They can tap into support coordination through core supports. This was a response with COVID, was to be able to tap into people's core funding. I'm going to assume some level of knowledge of NDIS plans, so forgive me if you're not aware of it, but essentially there's categories of funding. If the core supports is usually where the bulk of people's funding is, if they've got funding there, they will be able to tap into some support coordination supports out of that, which they ordinarily wouldn't have been able to do prior to COVID. Yeah.
Okay, so you can do that as a stopgap while you get the review sorted out.
I'm about 80% sure that that's continuing, but I don't know, Kate, whether that is continuing. Yeah, that it's going through core supports as well. Yeah. So essentially, the same line item for support coordination is available through both core and the regular category for support coordination, so people can tap into both. Yeah.
So there is a lot of complexity, obviously, as you're hearing in NDIS plans, and people have different categories of funding. But I think the take home for coordination there is that you can use your resource. If a person has an NDIS plan, they have resources, they can use those to get coordination, even if it's not specifically funded there.
As a short-term arrangement.
As a short-term measure while they're sorting out getting reviews and all that kind of stuff, because that can take time. Now, what's your experience of coordination between the disability supports that people have and other systems, you know, mainstream systems, whether that's the housing and homelessness, particularly, also other things like education or health, or how have you seen that working in your practice? Andrea, would you like to?
Yeah, hi. In Cairns, we've had some coordinated care working groups in the homeless sector already, prior to the Q shelter position coming up recently. We've also had it in the youth sector. So again, it's a matter of people meeting around the table, discussing various clients, you know, who are homelessness. But even to have that, you've got to build up that network, you've got to establish those groups. So without those, it's really difficult. You know, like we have recently done the Cairns TRI group, Cairns Housing and Homeless Integration Initiative. And that's been interesting because, or I've found it, you know, because I've worked in the disability field for years and years and years before NDIS, with mental health and disability services. So we've always had a network and I know who to contact, whatever, and I understand the systems in process. But without this TRI group, which is just starting, I'm learning in the homeless sector or in the community housing sector, the workers just have no idea of the NDIS sector. It's a matter of educating, which we have, like just by starting up the panel, by going through referrals, analysing, hey, this is what could happen, like we don't even need this referral to go through. Just explaining the roles of public guardian, explaining the NDIS sector. It's been, so it's to me, it's a matter of educating, but also building those relationships.
So is that going? Yeah, Mark.
Yeah, I just probably now is a good time to also add the new psychosocial recovery coach support option that's available, that may be in some people's plans. And I guess it's in some ways it's a recognition of those interface issues and that awareness of the mental health sector and the services that have underpinned that sector for a long time, and where the NDIS sort of interacts with those. So the idea is that it's, you know, in a similar sort of role to a support coordinator, but someone with specific either lived experience or their professional experience working in the mental health sector. And then they can assist people with the support coordination, but also in helping navigate the broader service system. So whether that's mental health or with housing or any of the other interfaces that are there. So that's a new support option, and it's certainly the market is nowhere near developed. It's only fledgling at best. But that's sort of where things are heading as well, is to open up that and have people, as you say, Andrea, who have got greater awareness, I guess, of the existing support services that are available and trying to work in with those.
Okay. It's also the homeless sector and the interface with disability, especially with psychosocial disability. And I do acknowledge the recovery coaches that are coming in. Again, I'm just wary of skill set because that's a huge issue across the board with mental health at the moment. Now, I'm just trying to think what I know the other thing, so since I've been on the panel with the new Q Shelter coordination initiative, it's interesting again in housing because again, you've got administration workers who are tenancy officers, so that's the skill, and the lack of knowledge with mental health. It seems to be this thing that with mental health, just give them more medication and they'll be all right. It's like ring mental health for anything, even if it's a behavioural issue. Clients have still got choices. It just goes on and on and on. But again, I think that's the more the homeless sector coordinates with the disability sector and learns, it will just continue to improve.
Okay. So
and I think,
yes, sorry, Kate, go ahead.
So a couple of points there. I think the initial part of the question around coordination. So, and in Townsville, we're the oldest market in Queensland, so because we rolled out first. So we've seen this and a real journey. So at the beginning, and because I was involved in our coordinated care group in my previous roles and connected to the homelessness sector really closely, always a part of CCG, and they had the integrated case management approach even, where we would go share client information and almost jointly case manage people to then the strategic alliance as well. So what happened at the beginning was that people didn't even know what NDIS was, what a support coordinator was, what the LACs could do. So we were kind of ousted from the process. So we were kind of saying, hey, let us in, we can help, you know, we can actually do some of that work and take that off you guys, and you guys can, you know, just focus on the homelessness stuff and we can do the other stuff. So we've moved from that space where that people didn't know what we could do or that we existed as a coordinator or as that kind of support to navigate the NDIS, to a bit of a flip now where it's like, well, if someone has an NDIS plan and they have a coordinator, you can fix everything and do everything. And so even just last week, we had a homelessness service make a formal complaint because we didn't, or the support coordinator didn't do the housing application for the person. And they have 2 housing services that work with them, NGOs. And have worked with them for 6 months as this person transitioned from other regional areas backwards and forwards. So it was interesting for me to then have a conversation with them and say, well, you guys are working with that person every day almost, and they're accessing emergency accommodation. Yes, they have a disability and they have an NDIS plan, but you are their homelessness case manager. So it'd be really great if you guys could do that housing application, because the flip side is that we're also fee for service and driven only by the amount of hours in the plan. So on average, people have 40 to 50 hours a year of support coordination. So if you think about that, that's maybe an hour a week, if that, because you have more time at the start, more time at the end. So really it might be an hour a fortnight. So that's not a lot of time, whereas homelessness services, especially some of your street to home, your assertive outreach programs, they're intensive. You're seeing your participants or your clients every day or every other day. So for us, it's also, some of that work is around building those relationships with the NGOs and explaining that it's not about us going, oh, we don't want to do that, or we're being lazy, or we're not doing our job. It's about, well, which parts can we do? So which part can I do? Which part can you do? How can we work that together? Because sometimes we have more hours and we can do more. And, you know, it's like, it's people, they're not black and white either. So it's this kind of, and that's where we often struggle too, because then we don't have the time to do that. So even attending CCG and attending integrated case management and all these wonderful coordinated things, we're not funded to do it. So for a support coordinator to go and attend for 2 or 3 hours, that has to come out of that person's plan. You know, so that's the other thing, that kind of trying to, I guess, educate the NDIS around that as well, that if people are complex, these are the things that actually stabilize supports and keep that together, and it's going to save you money in the long run. But it's also, you know, kind of working with the NGO sector around that too, around understanding where we're coming from and how do we all work together. And it's the same with health, you know, we have the same kind of stuff. But I also wanted to make comment about the recovery coach, and just to flag my own personal bias, because I am a support coordinator and we have one of the largest support coordination programs in Queensland. It is very, very confusing for people at the moment. So they're getting recovery coach written into their plans without request, without any understanding of what it is, without a conversation at a planning meeting. They have no idea what a recovery coach is. They have no therapy team. They have no recovery plan. And they go, well, I don't want a recovery coach. I want my support coordinator. And so some planners are saying you can't have both. Other planners are saying you can absolutely choose what you use your funding for. So choose, and that's my understanding of what the actual rules are. Like everywhere else, you can choose. And other planners are dictating, saying that you can have 24 hours of support coordination and 80 hours of recovery coach. So it's another layer of confusion, with not lots of information out there in the sector, even for us who do this every single day. So just flagging that for NGOs and others who are going, holy moly, like, what does all that mean? It's absolutely like that even for us on the inside, and we're feeding that information back. It's also really confusing to merge both the roles, because if any and the recovery, it was based on a clinical recovery plan that would be delivered in a day-to-day manner, so more of a day-to-day type support. That person would have qualifications and skills, and it wouldn't involve some of the tasks of a support coordinator. And the other challenge for support coordinators is that they don't have a program manual or a guide. So the NDIS have written one for recovery coaches, delivered that, it's out there, it says what a recovery coach should do, what qualifications they should have. Support coordination doesn't have that. So it's kind of a really strange way to deliver a new support. So continue asking questions, continue telling people you work with they always have a choice. A planner can't tell them exactly what to use their funding for. That's the whole point of choice and control.
Yeah, so and I'll just jump in there, and you know, and acknowledge that confusion, we hear a lot as well, and we keep pushing back to try and get more clarity on these issues. So totally hear where you're coming from, Kate. And and I'll just add, I think the point you raised about the NGOs in the housing and homelessness sector and their responsibilities, that's those interface issues. As you say, it happens with health, it happens with education. That's essentially most of my job, is talking to those different departments or other agencies about where the responsibilities start and finish between the NDIS, because everyone is still part of the National Disability Strategy. All government departments and NGOs and all that are playing a role in providing reasonable adjustment for people with disabilities. All of those things still apply. And so, and this is the evolution of a new scheme, really, is people finding out where those boundaries lie and whose responsibilities sit everywhere. So I just thought I'd add that while it's there in this sector, it's definitely there across all sectors to social services.
Yeah. And for me, what I'm hearing, the take home is people really need to have good relationships. And so then you can talk, you can sort these things out. So if you have a good network, if you know, if the support coordinator and the homelessness agencies are meeting regularly, or they know who each other are, they've got a good, strong network, then you can, if these issues come up, you can negotiate and you can sort out who's going to do what. What's really important is that someone doesn't end up with nobody doing the support that they really need because everybody says it's someone else's responsibility. And I think all the people around the table today would be very committed to making sure that doesn't happen, including all the homelessness services we have online.
I would add there too, John, that
Yeah.
yes, and people like Kate, it's really informed and can help to educate people else in the sector. But I totally acknowledge that the agency has a huge responsibility in trying to educate and clarify those boundaries and all of those sorts of things. It's a huge role for us to play in that regard.
Yep.
And just to add something else with that, I know that mental health struggle with that, is that when a client does have, maybe specialist support coordination, and the client ends up in the unit, has to be, ends up as an inpatient, mainly because of a homeless issue, that they've lost their housing. And I know at times we do struggle that, is it the support coordinator's role to look for housing? If there is the hours, it's a bit of a blurred line.
Yep. So we're kind of moving on. I know that within the homelessness and the social housing sector, a high proportion of the people who housing workers deal with are people who have psychosocial disabilities or have chronic mental illness. And that's a big part of the reason that they're in the housing situation that they're in, although usually not all of it. What are the key coordination challenges that are faced by people with those chronic mental health conditions, and how have you seen them dealt with well in your work?
That's a hard one. Again, in my role, service integration coordinator, the biggest part of my job is networking with other government departments and the NGO sector, and also doing a lot of the NDIS. And again, it's like I said before, it's educating about mental illness. That's just going to be ongoing. And I think with the new TRI, the Q Shelter initiative, that's starting to help. But I try in my position to involve housing, especially if there's eviction notices, things like that. Again, it's that network, but it's to educate support staff that this may be a mental health issue, or this may be behavioural, or it's self-medication, but it's an ongoing issue. And also Again, that's education, is that not all people are automatically are case managed in mental health. You know, like it's a primary health issue to start off with. I find it an ongoing issue, but it's educating and being part of those networks and say even setting up an NDIS plan at the right time with training of the you know, the support staff. And again, with the NDIS, we have got so many agencies now involved with offering support work, and the skill set is a lot lower compared to back when disabilities funded psychosocial, non-clinical. I used to only deal with 4 agencies with all our clients getting support, whereas now it's, you know, probably, I don't know, 30, 40. There's, yeah, because it's, you know, driven, yeah, NDIS is such a different policy.
Yeah.
So it's difficult.
One of the things, yeah, sorry, Kate, go ahead. Yeah.
From our perspective too, as coordinators, so we, same, you know, deal with lots of different services, but I guess some of the complex spaces that we come up to is the interfaces, but even kind of a higher level than that. So you will have NDIS rules, you know, like around this is a person's choice and control and it's their plan and they choose and da-da-da. But then you might be working with mental health where someone's under a treatment authority or a forensic order or something. And so mental health have, you know, the Mental Health Act and the rules that they operate under. And so you work with the treating team that is saying, this is what, you know, the TA says, this is what their forensic order says. And people that come from a real medical model sometimes in those kind of roles. And then again, you might have that person's family or their informal supports around them that are saying another thing. And so often the coordinator and the support service are stuck in the middle of that. And there's really limited spaces and places to get the support or kind of, you know, education and development in that space. So I guess coordinators and those services are trying to really, because this is such a new area, like I say, Townsville, we're a little bit like mature, you know, because we've kind of we worked a little bit of that out, and we created support coordination networks that were really essential to the coordinators connecting and learning and developing ourselves. But I guess it's also kind of making that a little bit wider and going wider out and saying these are the complexities, because before in the DS days or the block funded days, it just got worked out, you know, or it got handed back to DS and they block funded someone and it wasn't anyone's issue now. And yeah, huge issues even around that correction space of supervision orders. NDIS doesn't fund supervision. You know, so we've only even recently, as Brisbane rolled out, have those things kind of been ironed out. It's the same with child safety space, you know, the issues between who funds out of home care, NDIS versus child safety and lots of like toing and froing. So I guess there's been lots of examples of where even at high levels, government departments have had to come together. But what we see on the ground is that comes together up here. But down here, we're just still all like running around in the dirt trying to figure out what's going on. And it's, you just need to have those key relationships, like with Andrea's role and Andrea in Cairns, and we have one in Townsville and Mackay and Rocky that we work really closely with as well, and those guys are gold, because you can pull them in to resolve any challenges, and it's always just around misunderstanding. Everybody wants the same things. We all want people in stable housing, with stable supports, with things working well, but there's all these other external systemic issues, and not to mention bigger things like housing issues. Most communities don't have lots of spare houses lying around that are really cheap and affordable for people on a DSP. So we've got those issues on top of the disability needs, you know.
There's a question here, and just a good time to remind everybody who's online here, if you do have a question that you'd like the panel to address that's being prompted by this discussion, please pop your question in the questions box. If you look at the bottom of your screen, there's a Q&A little function there. So ask a question through that, or just use the chat function, and I'm monitoring both of those to pick up your questions. But someone has asked, given that there's a lot of that relationship building and kind of coordination meetings, are support coordinators actually funded to attend those, or how do you pay for that?
We're not. That's the issue. Unless someone is really well funded in their support coordination hours. So if someone has 100 hours, then you can possibly do that stuff. You can kick off and you can have lots of meetings and spend 6 months getting someone housed. And that's the concept, is that we do really intensive work and then get people housed, get supports in, and then we step back.
Yeah.
Like the point of us is we do ourselves out of a job. We're not meant to be around for a long time. But if someone doesn't have that, or you run out of money or hours and the NDIA won't fund anymore, they've got none left in their core, we end up delivering for free, or not at all. People just pull out. So that's an issue. Yeah.
So the wider networks, you know, where you build relationships with other services and that kind of stuff, how do you find the resources to keep doing that?
It's really difficult.
Yeah.
It's really, and smaller providers just can't. On a larger scale, when you get larger, you're able to do a little bit more of that. But it's really difficult. You've got to, I guess, weigh up the billable hours first. Yeah. And kind of, yeah, it's tricky.
Yeah. So I guess the thing for other people is just to be aware that your time is limited and to make really good use of that when you are there.
Yeah. And to also, I mean, Teams and COVID's been great, you know, because it cuts down heaps of travel time and everybody's online all the time, which is great for us. But yeah, and also to understand maybe there's some other things that you can collaborate on and work together that will free up some hours. But also, if not all coordinators understand that process either, and I've heard of some providers who just cease, they just stop. Like, oh, well, I've run out of hours, I'm not doing anything more. It might be also that if you understand the process, you can say, hey, do you know you can use CORE? Do you know you can go back to the agency and say, this person's homeless, they need coordination, they need another 50 hours, and you can ask for it and get it. So all those things can be resolved, and the NDIA are really good at listening and responding quickly. For such a large bureaucratic federal system, they really do flip things around and you know, review plans quickly when there is an urgency. So don't be afraid to ask and call your local office. And,
Yep. And somebody's up. Yeah.
Just with that too, I guess, and on in no way under the illusion that any of this is simple at all. I've sort of worked in the provider side of things around support coordination as well. So I totally get all the challenges that are there in the sector. I just wanted to add a couple of other possible sources of funding that may assist people that they may not know about, and that's not just in support coordination and recovery coach, but also there's a couple of other categories called capacity building improved living arrangements. And that's with, there is a line item in there and it is a lower hourly rate, you know, I know that, but they're called assistance with access and tenant, assistance with accessing and maintaining tenancy obligations. So if it may be that someone doesn't have support coordination, but may have that. Now, it's probably unlikely that it is put into someone's plan without it being asked for. But these are the sorts of things too, that the more informed that you are in helping someone have that conversation, you may be able to, you know, prompt that in the planning conversation to say, well, we need some help with tenancy, and, you know, managing tenancy last year was a real challenge and we only just managed to hold on to the tenancy arrangement. Can we get some funding in there for that? The other one is there's another rarely used category called capacity building, increased social and community participation. And this is around assisting in the coordinating of volunteer support. And I know that there are some certainly down in Brisbane where I am, where I know of some organisations where that's kind of how they do business. is they have a pool of volunteers, but they have historically been the ones to facilitate and bring in the right volunteer and match those volunteers with the right people. So there is an hourly rate available for that. Now, it's a very specific and nuanced way of doing business, but it is there, and there may be some people out there who, that's sort of some type of work that they've done in the past. Yeah.
Okay. Somebody's asked, how do you advocate for lots of support coordination hours in a plan, and especially for a first plan where there's not a lot of evidence around?
Really, I think it's about, if it's just the individual going to the planning meeting, then they need to present that themselves, but there may be a support person with them, and really presenting that case of why they need support, maybe some evidence of what's gone wrong or what's unraveled in a person's life recently that would, help support that argument. Yeah.
Yeah. And Mark, somebody's asked you to repeat the terms and the line items that you just used.
Yeah, okay, sure. So both of those categories are in the capacity building component of a plan. And one of them is called improved living arrangements, and the other one is increased social and community participation. So if you look up in the price guide, like the price guide actually has a brief description. And if you just Google NDIS price guide and look for the 2020 to 2021 on the website, and scroll down you sort of get to about page 60 or something like that, and you'll see these categories come up. And I think sometimes they might be a good way of fleshing out those sorts of issues when you're in the planning meeting, if you are supporting someone in the planning process. Yeah.
And Hannah has just popped those in the chat box for you to copy.
So I've seen them in people's plans, but they're not in a high percentage of plans at all. Like, it's a minority of plans, but I think it's the sort of thing if you ask for, and definitely if you were previously working with an organisation that was organising volunteers, then this might be the type of support that could help you.
Yeah. Okay. Any other thoughts about the advocacy for more support coordination hours from you, Kate or Andrea?
I've found if we've got planning meetings with NDIA, it absolutely, it happens, especially if the person's needs are fairly complex. And again, I think it's really important that there is a support person with the client. And again, I know with our clients with mental health issues, it's normally myself attending, it could be the public guardian, it could be a case manager, or if not, a carer. But I think it's important to have someone there and emphasising the reason why that it's imperative, especially with the person's disability and functional impairment.
Yeah. One of the things that I've observed a lot in working with people with mental health is obviously the conditions do tend to fluctuate. So you can have really good days, really good weeks, really good months, and then a person's condition deteriorates, and then suddenly they need a whole lot more support. That's often the point at which they don't realise they need the support, or they start to kind of, because their health is declining, they're kind of starting to piss people off or withdraw from relationships with people. How do you address those fluctuations in the context of providing NDIS support to a person with mental illness?
You get a really good plan in the first place.
Yeah.
So it allows you to have a safety net. And I know, Mark, you might want to shut your ears, but NDIS will tell you don't talk about your worst day. You have to talk about your worst day. Okay, because the planners aren't clinicians, so not all the planners understand mental illness. We've got awesome planners up here in Townsville, and Cairns have gotten really heaps better in the last 6 months too. But lots of planners are new, lots of planners are overworked and under-resourced and don't get the best training, like all of us in this space. You just got to do what you got to do. And so lots of them don't necessarily understand, sporadic nature, and that they are actually able to fund on that and different things. So we do still say to people, this is when you go into your planning meeting, you need to talk in a deficit model. This is totally opposite to everything we know as clinicians or practitioners or workers in this sector, where we're all strength-based and solutions-focused. And, you know, we can't do that with NDIS because they fund the deficit. They fund the difference between your disability's impacts and living an ordinary life. So we need to show them that part, not all the things we could do if we had, you know, if I had great funding, I can go to the shop on my own and I can join a club and I can maybe even go for a walk on the beach by myself. No, we need to be talking about what we can't do. So then they really clearly understand what to fund. Yes, it's going to get us to those goals and get us to that capacity building, but we need to be quite focused on that in the reports and the communication to the agency. Yeah. And we've found that gets you the best plans. Then once someone has a plan that is well funded, they can use it and not use it and use it and not use it. So sometimes when you're really well, you don't need much support at all. And then all of a sudden you become really unwell. You need daily support. You need an increase in therapy. You might need all sorts of things, even overnight sleepovers, and you can get it. But if you don't have a good plan and you need to go through that kind of process of going back and forwards and getting reviews and delays, it's the delays that really impact people. So we've learned that if we can get a great plan and that person, whether they spend it or not, use it or not, it's there as that kind of, that's the best way to support people. Because people that are also experiencing psychosocial disabilities to that extent, they don't need to be going for review every 3 to 6 months. They don't, just talking to the agencies is huge anxiety for them, you know, or another thing to do, another thing to think about. So it's kind of trying to make that navigating that complex system as simple as possible.
Yep, and it's Andrea, my other experience with, again, with the psychosocial disability, like a lot of our clients with complex needs and have good plans. But I find in my role, I'm doing a lot, and also Mercy's support coordinators are also, we've got to constantly be in touch with the support agencies to find out about what's going on with the support. Because again, with the lack of skills with the support workers, they're not seeing, you know, like the signs of deterioration in a client. Then it turns into a, you know, a complete mess, not seeing those warning signs, not realising that, gee, missing medication is pretty important, and getting, I know I've just got an email before sort of pointing out all these things that haven't been happening with this client, and now it's nearly a fortnight, like missing medication, not eating properly. There's now you know, neighbours are complaining about his behaviour, and again, it's his, you know, positive symptoms are coming through, and again, you know, there's negative symptoms, but just not being aware who to contact, when to contact, and the importance of it. Yeah,
and so it sounds to me like it's really important as well for someone, if they're in that position where their condition does fluctuate, that there's someone in their lives who knows them well enough and is well enough in contact with them to pick up when that's going on, so they can then help them get the support they need.
Yeah, but also with that, when you've got a support agency going in every day, you hope that you're getting notified earlier, and unfortunately that doesn't always happen. Yeah. At the moment. That's where, and that's again, it's skill set. Yeah, so, and again, you know, NDIS is new, so let's hope the workforce become more skilled.
So I have another question here that someone has put up. How can a good NDIS plan support drug and alcohol recovery? For instance, related to an ABI or a trauma or an injury. How do those two systems interact?
So NDIS doesn't treat alcohol or drug addiction or AOD challenges. So you do need to be careful, and if you start talking about that in front of the agency, they go, oh, we don't do that. So maybe don't talk about that as much in your reports or in your communication with them. But if someone has a disability, and that's why they would have an NDIS plan, and then on top of that, they have a drug and alcohol problem, like many people in Australia do, you know, it doesn't discriminate whether you have a disability or not. The agency would see that as two separate things. So they would see that we're funding an NDIS plan to support that person's disability, whether that's an ABI or maybe quadriplegic or something, you know, we'll fund the supports around that. And then your AOD issues would be, in their view, the role of your Queensland Health or your health systems or your mainstream drug and alcohol systems. But that doesn't mean that we don't work together. So what we have done in the past, like with our participants, is that maybe their NDIS support, so their day-to-day support workers, take them to their appointments, you know, because the person can't go out in the community without support. So that would be a good use of their NDIS plan. But then those appointments or that treatment for alcohol or drug addiction is delivered by an NGO who's funded to do that, or by the Queensland Health Service. So for example, we have people on the methadone program, they have day-to-day supports because they also have schizophrenia or whatever. So their support workers would transport them to their appointments, you know, support them to understand their appointments, maybe support them at home to have a calendar and you know, planners and things like that, because they're the things that will maintain that level of support and allow that person to continue with treatment. But NDIS won't fund the actual treatment. That would still be funded through mainstream. Yeah. Is that right, Mark?
Yep, that's a good summary. And the same principles that you've talked about apply to all other things. So if you think about schools, a kid with a disability is still entitled to an education. The education department's still going to be providing all of those things and the reasonable adjustments that go with it. But there are certain supports that are going to be required to access their education, and that's what the NDIS, you know, so it may be that they need their, you know, equipment to get around the school. Similar, I think Kate's example is really good, where the supports are there to get to the program that's required, but the program itself is still funded by whatever applicable agency or department needs to do it. Yeah.
Yeah.
But just one other thing I'd add is we do have some questions around at the access point in eligibility and differentiating where the drug and alcohol influence is on the person's disability and where the actual other aspect of their disability is. And so one piece of advice that the agency gives is, if there's been a period of abstinence and there was evidence that there's still support required in that period, then that's always good to support the argument. But I'm sure Andrea's got much more experience on navigating that area.
Yeah. Got anything to add to that, Andrea?
No, we seem to have it, you know, under control. Like Kate said, you know, a lot of people self-medicate, and yeah, you know, especially with severe mental illness, you know, yeah, there's a fair bit of self-medication going on. The other thing though is to remember that with alcohol and drug services, it's voluntary. And so for people to understand, it's up to the client that they want to, you know, engage with ATODs or the other NGO sector.
Yeah.
And mental health do not force.
Okay, thanks for that. Last question that we had prepared. Oh no, second last. I know that a couple of you, as we've said before, have been engaged in the homelessness coordination and the housing coordination world, and you're also engaged in a whole lot of other coordination work around your other areas of work. What would be your observations as to how housing and homelessness workers could better work with disability services in that coordinated way? what advice would you have for those housing and homelessness agencies for how to interact the best?
I think the first part is to, and I know it's not easy either, and everybody's really, really busy, and especially those guys working on the ground in some of those outreach programs, you know, that's some of the hardest work that you can do. But I think it's really important, it's everybody's responsibility to have a really clear understanding of the systems that we work in. And just like we all learn how to do a housing application, and we all learn about how to work with mental health, or what the rules are around that, or Medicare, or your GPs, NDIS is the same. So as a case manager or a team leader or a housing service manager, it's really important that for those guys to connect into the NDIS space and network with the support coordinators or the services in that space, so that they can collaborate, because in a way they have a little bit more capacity than the NDIS services do because of our fee-for-service model. Even support workers, you know, they're funded for the 3-hour shift that they get with that person each day, nothing more, nothing extra on that, you know. So if a housing worker wants to learn or engage with them, the best option would be to go meet the person when they're on shift with the participant, have a yarn, do that stuff at that point, engage together, you know, attend stakeholder meetings, collaborate, because that's how we do the best work, is together, yeah, and everybody wants the same thing. So I think it's just about gaining that understanding and reaching out and seeking that out, and kind of yeah, doing that with an open mind, you know, and yeah, and then I think we can all work together and collaborate and get the best outcomes. That's what I would say.
I would just add there, sorry, Andrea, just this afternoon, our community engagement team is doing an information session for Toowoomba in homelessness sector. So it's sort of a bit of a pilot, I guess, to see how much interest there is and what sorts of questions we get from NGOs and the like. So we'll be discussing some of the options that are available and all that sort of thing. So hopefully, if it goes well and we sort of hit the mark, then we'll try and do more of that type of work throughout all the regional areas and Brisbane, of course. And I guess one of those things that I just wanted to also add is about individual living options, which is another new sort of way of delivering support that the NDIS is looking at. And it's, if recovery coach is new, then this is absolutely embryonic. But there are, it's probably not going to hit the mark for a lot of people we're talking about today, but there might be one or two where an individualised living arrangement with a host family, or a host arrangement with a co-tenant, these sorts of individualised options are now being explored, and yeah, possibilities in the NDIS as well. So we'll be talking about that in more detail in these types of sessions in the future.
So one of the things to be aware of in the NDIS is, ever since it started, you know, it's a system that is continually learning. And so there's been a whole lot of new stuff. Even since I did those workshops last year, there's a lot of new stuff that has rolled through since then. You know, the recovery coaches, the individual living options, some of those kind of things are quite new, and there's more coming online all the time. So if you're working a lot with people who are in the NDIS and have NDIS plans, it's really good to just have a way of keeping yourself up to date, whether you subscribe to, you guys, Mark, have a regular newsletter. And
we're doing different updates. Now with COVID as well, we're sort of exploring the best ways of getting that information out.
So work to keep up to date. And if you have some people who work in that system in your housing coordination networks and that kind of thing, then that's a way of you staying up to date as well. Did you have anything to add to that, Andrea?
No, just that, well, the initiative of Q Shelter, I think, has been good, but I think it's only in 9 areas throughout Queensland, and it'd be good to see that continues to be funded, because you do need a paid position to keep those agencies all together, and so far, I think we've only been up and running because of COVID. There was, it slowed down a bit. But yeah, just the community housing organisations, the stuff they're learning is, you know, fantastic, and the networking excellent. And that's the whole thing. It's building those relationships and sharing your knowledge. Yep.
So if you had one wish to improve coordination across the disability and housing sectors, what would be your thing? You know, the genie comes out of the bottle. All right. And he says, you have one wish. What would you wish for?
My wish is, and this is going back, and I don't want to go backwards, but is when we were, you know, in the disability sector, we had a HAS program, Housing and Support Program, where the client got mental health non-clinical support, as in now they get NDIS, but it was a partnership with housing. So once that support came through, a house came through. So again, and I know it's a state issue with social housing, and it's federally funded NDIA, but we need governments talking and more partnership, because at the moment now, for our clients at mental health, I've now got clients, which is fantastic, have got all this non-clinical support to live independently in the community, but there's lack of housing. And even with, if they qualify for supported independent living, yeah, there's no housing. So now we've got this issue. So that would be my wish, that, yeah, it came together.
Yeah, that we need the housing response that goes with it.
Absolutely.
And all the housing agencies and advocates around Australia were advocating in the COVID recovery for extra social housing funding, which is a great economic stimulus, but wasn't successful. So we live to fight another day on that topic. Do you have a wish that you would wish for, Kate?
I like Andrea's because yeah, I think Townsville and Cairns are getting really great plans, you know, and in that psychosocial space, getting really great funding, but it's around the housing, but also the support and like you say, Andrea, the skill levels and the training and the development of staff, and it goes for coordinators too. We're a provider like anyone else, but particularly support workers, they're the key to people living their best lives. And if we don't support development and training and enable that to happen, and we create a free market that's kind of dysregulated in a sense, where there is possibly intent to make money over quality, there is a huge risk there without some intensive sector development. And I just think one big, huge thing that the NDIS hasn't really done that well has been the sector and community development. And I think that's why you see the mess on the ground, and even within high levels of government, like I talked about before with child safety and corrections, you know, they only just sorted that stuff out in the last year or two, and only when Brisbane kind of rolled in because they realised it was a problem. Like most things, oh dear me, it happens in Brizzy now, we've got to do something about it, you know. So I think that whole sector, community development, that as providers, as communities on the ground, I think that's a big part of why we're still struggling to build rapport and relationships and understand each other's roles, you know. That could really, really be keep of free training, keep of free networking, you know, like what your workforce council used to do, and cool stuff like that. I think that's the stuff that people need.
Yeah. you might not be allowed to have wishes, Mark, as a public servant, but do you have anything to add to that?
Oh, I think obviously, yeah, I agree with what both Andrea and Kay said, and I think that it's that, and Andrea touched on it right at the start, is the awareness of like the actual knowledge and awareness in the sector at all levels. So Kate talked about that at the planner level, where it's critical that the plans are right to start with, and then support coordinator level, so they know where to, you know, what there is out there and where to go to. And then obviously the most, you know, then there's the support workers, the ones that are actually at the coalface delivering supports, is where it's absolutely critical to have that knowledge as well. So I think I used to be a teacher back in the day, and I remember a really great principal telling me that the most important thing is the teachers and the teacher aides that are actually in the classroom. They're the ones that are interacting with the students. That's what it all boils down to. And all of these things have got to be right for the service to be the right service for the person in the end. So yeah, I think it's that education across all levels and increased awareness of the particular needs of the people we're supporting.
Yeah, I remember when I did the training, one of the things that really came home in that was that, you know, the NDIS compared to the previous state funded systems more than doubles the size of the disability support system. And what that means is you've got this whole need for new staff. And where do you find them? Where do you find skilled people? And so there is, and I know that there was a whole lot of workforce strategy around that, but it's still a lot of work to do in having a workforce that's really skilled. And this stuff is the really complex stuff, you know, helping someone cook a meal and, you know, go to the toilet and that kind of stuff is comparatively easy, although absolutely essential. But some of this coordination and understanding people's complex needs really is high level skill, and we really need to keep building people's skills in that. Now, there's a question here for you, Mark, which others might have some insight into as well. Could SDA housing be used in a psychosocial model and not just used for high physical needs?
The short answer is yes. So one of the SDA categories is, well, there's 5 different categories. There's high physical support, and the other one that's around physical support as well. Name escapes me. But then you've also got your standard sort of arrangement where there's some modifications to a home, which would be more like the old sill houses that maybe are housing 3 people without a physical disability. And then you've also got a category called robust, which has some special design features in it that may be for someone with, you know, behaviour concerns, so unbreakable glass, line of sight throughout the house, possibilities for the support workers, that type of, so not just in the physical makeup, but in the design of the house as well. So the robust category is one of those. And I know just anecdotally that a lot of the feedback that we get is, you know, that there's more demand for robust out there than people might think. What's happening? Are people building these sorts of homes? That type of thing. So that's definitely one. Yeah, so there is options out there for SDA. And I think that those people who need that type of SDA category may also then be fitting into the specialist support coordination. You know, they may sort of tie in together, which is something that Kate referred to earlier on as well.
Yep. So the answer is it can be done. Obviously, you need to have SDA in your plan. So
yeah. So yeah. Which means you need to demonstrate that there's nothing in the regular housing market that meets the individual's needs, and so they need a specialised design to meet their needs. Yeah.
Yeah.
Were you talking about SDA or STA?
Well, the question was SDA with a D.
SD.
Yeah.
Okay. Yeah. Yeah. Because STA you can use for when people are homeless.
So can you explain? Can you explain those two things?
And MTA.
Just those three sets of initials: SDA, STA.
Yep. So SDA is specialist disability accommodation, and it's bricks and mortar. So it actually pays for the building. It doesn't pay for supports. Then you get supports on top of that as well. And specialist disability accommodation is normally like a new build or a fairly new house. Big, long process to get your eligibility for that. You have to have really high complex needs, and that's all on the website. STA is short-term accommodation, and MTA is medium-term accommodation. So STA is kind of like the old school respite, but not. And MTA is just the accommodation. So it's medium-term accommodation. STA, you're only meant to have about 14 days or 28 days in a year funded in your plan. But depending on someone's situation and complexity, they can use STA however they kind of choose to use that. It comes out of their core flexibly. It doesn't need to be a stated support. Lots of people think it does, it doesn't. And lots of times people will use their STA while they're waiting to transition into a SIL. So they may be discharging from hospital. They may go out into an STA property or accommodation. A provider can even rent a room in a hotel or an apartment or a caravan park, because STA is funded at a daily rate, and it includes everything: food, transport, activities, because it's big money. It's like $1,500 or $2,000 a day almost to support someone 24/7, and it includes all their accommodation and all their supports. So if you've got a gap between, you know, somewhere an accommodation and the only other option is homelessness, and their disability needs are such that they do need that level of support, then they could potentially use their funding and, you know, not be homeless for a few weeks while they do that, if they have that level of funding. MTA is medium-term accommodation, so you can use that for up to like 90 days or something, I think, is the kind of concept. Again, the concept is that you should have a plan, so you should have accommodation to go to, and it might be that stopgap in between, and it actually pays a daily fee for the accommodation, not just the support or not just the bricks and mortar, but it's heaps lower, and then they may need support on top of that, and then it won't pay for their food and all the other stuff. I think it's about $200 a day or something, $190 a day. So we're doing a lot of that up here at the moment across our region, because it takes time for new accommodation services to be set up, and we're trying to set up whether that's someone's, you know, housing unit that they've been approved for and it's coming, or whether that's a SIL, and we're matching and doing some trials also, because people choose where they want to live. Like you don't just want to move in with a random, like you need to make sure that it works and it's all, you know, going to be suitable. So there are other options that your support coordinator or your specialist support coordinator should be talking to the person and their decision makers or whoever about as well.
So these are things you can use, for instance, if someone's being discharged from hospital or whatever, and they can't go back to where they were straight away, or so there's a bit of a need for an interim thing while their long-term option is being set up.
Yeah, so a good example, as Kate said, would be someone who's in hospital. They may have had a catastrophic spinal injury, been in hospital a long time. Specialist disability accommodation, SDA, is being established, and their discharge date comes 2 or 3 months before the build's going to be finished. Then medium-term accommodation might be the solution for them to go to. They might need more support hours because the accommodation's not quite right. And then once they get to SDA, they'll be able to do more things independently because it's all got all the bells and whistles that it needs. And they might have a bit less support, you know, on an hourly rate. So but the important thing with MTA, the medium-term accommodation, is it should have an end date. As Kate said, it should have a plan attached to it of when it's going to end.
Yeah. Otherwise, it just becomes long-term by default.
One of those, yeah. I mean, no one wants that.
You're stuck in something that's not quite appropriate forever. Yeah. Okay. Look, I don't have any more questions on the list, and we're nearly at 11:30. So I think that's probably a good point to wind up. So could I just say thank you very much to Kate, Andrea, and Mark for giving us your time this morning. Thank you very much. Really appreciate your wisdom and your knowledge of this sector. And there's so much more that we could talk about. And thank you to all of you who've been participating and putting up questions to stimulate our discussion. Thank you very much. There's some very insightful and helpful questions there. Hannah, last words for you. You're silent at the moment.
Thank you. Thanks, John, for facilitating today, and to all of our panelists for participating, and for everyone who's joined us today for your thoughtful questions and engagement. I would just like to remind you that this webinar will be available post-session for download, and also that you should have received a survey in your email about 25 minutes ago. If you could complete that and send it back to us at Q Shelter, we really value your feedback, and it helps us to structure our sessions in a way that's helpful to you in the future. So we'd really appreciate if you can do those. And thanks.
Thank you very much, and hope to catch up with you again at some point soon.